Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm joined today by Dr. Daniel Hofer, a family physician and a palliative medicine physician who specializes in community-based palliative medicine. He works with Sharp Health in San Diego, California. Dr. Hofer, it's all yours.
Thank you, Larry, and it's certainly a pleasure to be here again today. Today we're going to talk about geriatric frailty. You know, I used to do physicals on my patients, and I would ask them, well, what did your mom or dad die from? And they say, well, my father or mother just died of old age. And the reality is nobody dies of age. Age does not kill people. There must be something that's going on. And people are becoming more aware of frailty, but they're not really sure what frailty means. This is a particularly important diagnosis because it helps us to understand the inevitable consequences of the progression of illness for these patients and the increased risk they have for the treatments and procedures that we perform on them. So I'm going to go ahead and get started. So I have work as a consultant, a paid consultant for multiple groups. These are those groups. It shouldn't conflict with anything we're talking about today. We're going to talk about frailty syndrome, discuss the importance of the syndrome, and we're going to discuss treatments. So what is frailty? What is the definition? This has been adapted by the American Geriatric Society. This is a physiologic syndrome characterized by decreased reserve and diminished resistance to stressors resulting from cumulative decline across multiple physiologic systems and causing vulnerability to adverse outcomes. So what does all that mean? This is like an old car, 400,000 miles on it, still have the original parts. And everything's kind of worn out, but the car is still running. It doesn't matter, however, what part starts to deteriorate, the whole car is probably going to be done if something declines. And just like the car, our elderly population can develop this syndrome and they're at risk if something happens to them. We need to be really careful about what types of recommendations and procedures we perform on these folks. Just like other issues, frailty should be thought of as a condition with a lack of physiologic reserve. There's no ability to regenerate, to rebuild yourself if your body takes an insult. And frailty is progressive, so you can watch it over time getting worse, and you can understand how to guide your patients and families in the inevitable progression. And it's independent of other medical diseases. This is fundamental to frailty, which is why we're going to talk about this in a second, why so many frailty models are probably not actually frailty models. It's a remarkably expensive disease. Pre-frail patients add healthcare costs, mildly frail patients and truly frail patients are going to increase the cost of your care. And if you can identify these patients and proactively manage them, give them better guidance and treatment options, you can probably reduce some of that cost to the healthcare industry. So what is this physiologic reserve or physiologic excess? You know, people were born with physiologic excess. We have lots of duplicity, and we have to burn through that duplicity before our organ systems start to present symptomatically with failure. And here's multiple examples of physiologic parameters which have been validated. They take about 70% of loss before any evidence of failure is noticed, and that's myocardial oxygen consumption, hemoglobin dissociation, pulmonary issues, hematologic, renal, hepatic issues, blood sugar. It takes quite a while for your pancreas to burn out before you become a diabetic. And then most people don't even know they have it anyways. Cognitive status is the same way. And you can look at many conditions and see it takes a while to burn through our physiologic redundancy before we start to deal with our physiologic reserve. So why do we recognize, or why don't we recognize frailty? Well, it doesn't fit a classic disease model. This is not an organ system, this is a syndrome. And it's a gradual decline that we may not appreciate, or we'll just think it's normal aging. And this is a decline in strength, function, nutrition. In fact, it's a deterioration over multiple systems. A lot of people just say, well, that's normal old age. Well, and that's kind of true, but there's things that should mandate a clinical response if you know a patient's frail to help them slow the deterioration. and it may not be appreciated until it's much too late. And that's both by patients, families, and healthcare providers. So one of the pearls I can give you is that frailty is frequently not identified until late in the process. And then by the time you've identified frailty, if it's late in the process, there may be nothing you can do to prevent the inevitable consequences of that progression. So what is in fact the phenotype? This is from the American Geriatric Society. This was originally done by Linda Fried. It's now called the Fried-Hopkins phenotype. It requires 3 or more of these clinical syndromes. 1 or 2 of these identifying features is pre-frailty. If it's none of these symptoms are there, the patient is not frail. And the more features the patient has, the more frail they are. But that's loss of strength. So muscle strength, you can use a dynamometer to manage grip strength. You have to look at the patient's age and sex and determine if they're in the bottom 20%. Or you can use other surrogate markers to look at loss of strength. Weight loss, which is unintended, 10% of body weight or 10 pounds over a year. Decreased activity level, so these patients aren't getting out as much. They may be sleeping more. If they do go out, it's exhausting. They just get wiped out from going to do anything. And they have slowed performance, so unsteady gait, slowed walking speeds. They're just starting to slow down. If a patient has 3 of those phenotypic features, then that patient is considered to be frail. The problem right now is that we've been trying to look for easy models to put into computers or to screen for patients, and we now have 60 models for frailty. Most of those models simply list a bunch of medical diagnoses that the patient may have. But I'm going to show you why those models are not actually frailty, and in fact, they are multimorbidity or multicomorbidity. And if you have a real understanding of frailty, you'll do a better job prognosticating and managing these patients. So there's multimorbidity and comorbidity. It's not the same as frailty, and disability is not the same as frailty either, and we'll talk about that in just a second. So this is what you need to think about. In fact, I love this Venn diagram because healthcare used to be practiced with the top 2 circles only. There was disability and comorbidity. And in hospice and palliative medicine, this is how people saw the end-of-life experience. Now we can look at frailty as a layered problem on top of that. And of course, it's our fault people are living so long, but people are just wearing out. And that makes our job even more complicated when we look at these patients and make recommendations. And it should lead to different clinical treatments and different ethical mandates in the discussions we have with these patients. I would point out that frailty is not the same as disability. You look at those 5 phenotypic criteria, and my best example is to think of Terry Schiavo. She was a young woman who had cardiac arrest, and she has most of the features of frailty, but she has significant physiologic reserve. She has significant stem cell mediated recovery for her organ tissues, and that's why you have to know that frail patients don't have that stem cell mediated recovery. And those patients, when they take a hit, when they're frail, you know, they're in the hospital, they have a surgery, they get an infection, they do not recover to their previous level of function. Disabled patients, somebody who's been in a motor vehicle accident, had a young person with a cardiac arrest, those patients continue to have physiologic stem cell mediated recovery, and those patients are disabled. What do we need to know about frailty? There's lots of secondary features. You can see some cognitive decline. They might have mild cognitive impairment. They may have balance issues, motor processing, emotional status changes, poor self-rated health. They may be deficient in social support. That's very common because it's an insidious process, and we need to be looking at social determinants to help these patients. It's a complex problem. It's involving multiple hormonal systems, neuroendocrine systems, inflammatory processes. You get into anorexia of aging, and you can proceed all the way down to frailty and disability and dependence. Factors associated with frailty include acute illnesses go up, falls, they'll have worse or new functional impairments, They're more likely to be institutionalized. Lengths of stay in the hospital will be higher. They'll be on more prescriptions, much higher expenditures for these patients, which I showed you previously, in hospitalizations and death. The thing you need to recognize is that one of my geriatric colleagues stated that frailty imparts an exponentially increased risk of vulnerability to disease and death. So a frail patient is that person when somebody says there's a 5 or 10% chance of something going wrong. This person may very well be that 5 or 10%. When you look at the needs for these patients, it's also complicated because these patients not only don't drive their car, they have a hard time walking across the room. So they have transportation and mobility deficit. They are highly financially restrained in many cases. And with the lack of social and family deficit, it's hard for them to get the care that they need. They may have the beginnings of cognitive deficit, and this all leads to compliance deficit. There's 2 types of frailty. This is particularly important. And I would say that if you're looking at a frailty model, ask yourself if this model would diagnose primary frailty. If it doesn't diagnose primary frailty, I wouldn't use it. And primary frailty is frailty that occurs with the absence of significant overt disease. So this is not a heart failure patient that's become frail, or a COPD patient, or an end-stage renal patient. They may have early COPD that's not clinically that bad, or stage 2 heart failure. They may have a creatinine clearance of 30, which would be chronic renal insufficiency and mild to moderate deficiency. But these patients clearly are not suffering from their end organ disease. They're suffering from the expression of the frailty syndrome, and I'm going to talk about the pathophysiology of that. Secondary frailty is the one people think about with these other models, and that's because that is an expression of disease that is associated with another advanced disease process. We used to use the phrase, for example, cardiac cachexia. It would be more properly diagnosed as end-stage cardiac disease with secondary frailty, because that's the process that's occurring to associate the decline with the cardiac condition. Secondary frailty has a much worse prognosis, even worse than primary frailty. In fact, there's a 600% increased risk in mortality over 4 years and 1,000% increase in morbidity for these patients. So what is frailty from a cellular perspective? Well, we are born with a finite capacity for stem cell mediated repair after chronic exposure to tissue injury. Once the capacity is exhausted, a cycle of pathologic inflammation ensues that leads to overt disease manifestations. It is that cycle of pathologic inflammation that defines frailty, because we no longer have the stem cell mediated ability to repair our bodies after chronic exposure. This is a disease of the elderly, because we've worked through all of our physiologic redundancy, and now when you take a hit, because we can't do stem cell mediated repair, that injury leads to inflammation, and hit after hit raises the inflammation over time. The prevalence of this problem is very common. 1 out of 14, about 1 out of 4 of your patients age 65 and older are frail, and about 30 to almost 50% of patients over age 85 are frail. So we should be making this diagnosis routinely in our practices for our geriatric population. And the phenotype was actually validated in the cardiovascular health study and the women's health and aging studies 1 and 2. What's the pathophysiology of the syndrome? We talked about the cellular, the pathophysiology. It's a loss of skeletal muscle. That's called sarcopenia. You lose your skeletal muscle. And that's important because we've learned that adipose tissue is secreting pro-inflammatory cytokines, and your muscle is secreting anti-inflammatory cytokines. So it may be this ratio of loss of muscle and adipose tissue that's determining how rapidly your frailty accelerates. We know starting at the age of 30, you start to lose muscle, and that will accelerate after the ages of 50 to somewhere around 70, 75. And it also includes visceral protein. We've actually done the animal studies where we infuse pro-inflammatory cytokines into animal studies, and that suppresses biomarkers of frailty, such as albumin. It has to do with the neuroendocrine dysfunction that occurs as we age. And these are surrogate markers for the underlying inflammatory process. Multiple hormones have been looked at. I wouldn't recommend substituting any at this point. We don't know if that helps or makes it worse. We just know that they're surrogate markers to the manifestation of frailty. And the bottom part of this is the inflammation process. Those pro-inflammatory cytokines, IL-6, surrogate markers such as C-reactive protein, IL-2B, all of these pro-inflammatory cytokines that determine the frailty process. When we see these processes occur, you'll start to see declines in muscle function, neurologic function, energy metabolism. This is why when you give a feeding tube to somebody who has advanced frailty, the decreased energy metabolism isn't because they're not eating, it's because they can't metabolize the nutrition. It does not matter how much nutrition we stuff in that person's body, the machinery cannot metabolize that nutrition. We see immune senescence as people get older, and it's related to this process. Endocrine function, hematopoietic function, they're all related to the ratio of the pro and anti-inflammatory cytokines and the frailty process. So what's going on from a cellular chemical level? Again, it's this pro-inflammatory cytokines to IL-6, the tumor necrosis factor, we now call it cachexin, versus anti-inflammatory cytokines such as IL-10. It's a balance of cytokines over time that now that we cannot have stem cell mediated repair starts to cause more inflammation and that ratio changes. It's a third endocrine process. This is an example of pro-inflammatory cytokines, and you can see the inputs into accelerating or making better the inflammatory process. And you can also see the catabolic processes that occur from elevated pro-inflammatory cytokines. This relates to sarcopenia and cachexia, bone disorders, blood disorders, Alzheimer's disease, cardiac disease. Every time you hear a research article or a physician say, well, this is just found out to be another inflammatory disease, inflammatory related disease, this is what they're talking about. And the same thing goes for cognition. We know that cytokines increase the risk of cognitive decline and increase the risk of cognitive impairment in our patients, which is why when a patient is particularly frail, and even if they don't have any cognitive damage yet, it accelerates and increases their risk of delirium and potentially dementia down the road. You get to see this in the news, and of course our patients read about this, so we need to be ahead of the game when we're talking to them about what it means to be frail, and what frailty is doing to cognitive implications as well as functional status. So when you think of muscle loss, it's particularly important, especially when you put an elderly person to bed, because as we're getting older, these patients are getting weaker and our muscles are secreting anti-inflammatory cytokines. But one of the things we can think about in frail patients who have already lost a significant amount of muscle mass is that when you put that patient to bed, they're going to lose 5% of their muscle strength per day. And since most of these patients will be in the hospital for a prolonged period of time compared to usual patients, we need to recognize that a week in the hospital, this patient who's already frail, maybe walking around the house with a front wheel walker, is not going to go back to their previous level of function. And it should not be assumed if you're a physician who's working in the hospital that you can just send them off for rehab and they'll return back to normal. We know that that is not true. And so the research doesn't support that, and we need to be aware of that, and we can explain to our patients why that problem occurs. Now that compares to us. If we're in the hospital for a week, we lose about 1 to 1% of our muscle strength per day, and we have the physiologic reserve to recover. And so we do very well. Frail patients don't have that reserve, and they do not recover back to where they were before. So be cautious about what you tell your patients about the benefits of an intervention or surgery. And many of us have had the experience of sending, for example, a knee repair or hip repair to surgery. The hip replacement is perfect. The knee replacement is perfect, but the patient can't walk anymore. They're having difficulties that they were having, more difficulties than they were having prior to the intervention. So why do we want to address these outcomes? Well, just for what I was talking about, these patients will maintain a higher functional status, even if it seems like the intervention would help, but you can also help them prevent other things such as falls. They'll have better quality of life. It's a choice between two different pathways if you're introducing a treatment or intervention. But you can also help patients, if you catch frailty earlier, to have a better quality of life. And for both patients and families, they want to know that we understand the process and we can define what's coming for them. That makes them feel as though we are acquainted with the disease process and we know how to guide them in the inevitable consequences of the progression of their loved one's illness. I would point out briefly, and we'll talk about this a little bit more, but since actually I can go back to 2012, 2016, and this year in 2020, the National Surgical Quality Improvement Program has asked us to screen for frailty on every single one of our patients age 70 and older, even if it's an intervention. Doesn't matter what the procedure is, because the value of knowing that before you send a patient to surgery is significant. This is an index evaluation, cumulative frailty characteristics, and predicting postoperative discharge institutionalization. But this is a frailty index. It looks at a lot of different metrics when you're deciding whether a patient's going to get institutionalized. And this was for patients going under major procedures with ICU stay. And you could look at these patients. This is not that old to me. I've taken care of a parade of 90-year-olds. So when I see 73, it seems rather young. But these are frailty characteristics. You can look at the prolonged timed up and go test, any functional dependence, older age, Charlton index of greater than 3, equal to 3, hematocrit albumin or a mini-cog. You can look at those and say, if any of these are deficient, particularly functional decline or prolonged time up and go test, this patient, if it's going for a procedure that involves the ICU, is going to end up institutionalized, highly prognostic. And you can ask yourself, is that a piece of information your patient and family would want to know before the patient agreed to be to attend the surgery you've recommended? This is another research article. This was from Martin McCary. He works out of Harvard. He looked at frailty as a predictor of surgical outcomes. He compared non-frail patients to pre-frail to frail patients. And you can see for a major procedure, you should expect your frail patients to be in the hospital twice as long. In the hospital twice as long, losing 5% of their muscle strength per day. They're going to have more complications. That can't be a surprise. More than twice as many complications for a major procedure. Minor procedures, even 17% of these patients will be discharged to an institution at some point. And that's compared to less than 1% if the patient was not frail. For major procedures, it's 42%. That's 14 times higher than the patients who are not frail. So it's a different subset of patients. So what's the treatment for frailty? Now, this is a busy slide, and we're going to break this down in just a second. But there's many things that we can do to help frail patients do better, whether they're going to surgery or not, or going to the hospital or not, or going for an intervention. But these are things we can do simply by identifying they're frail, that they are frail, but you have to catch it early, and you have to recognize that there is an ability to slow the inevitable consequences of the progression of frailty. So you need to have age-appropriate exercise. There is no person at any age that I do not ask to exercise. It just needs to be age-appropriate. And we know that issues such as lower extremity resistance training, even in the elderly, is important. So that's something that usually gets left out. We tell them to do cardiovascular exercises, maybe lift a few weights, so they're making their arms stronger. But resistance training for the lower extremity doubles their leg strength, increases their walking speed, increases spontaneous movement. These all relate to frailty, so I would encourage people to include this in any exercise programs you give to your elderly patients. This was validated in the importance of this and the fact that physical inactivity was the strongest correlate of body composition, which, as you know, relates to frailty from the Journal of Clinical Nutrition. And so we looked at people who were exercising daily versus those that weren't, and physical inactivity just showed that the normal progression of muscle loss to fat gain was markedly higher in patients who were not exercising. And there was an inverse correlation between calories burned per week during exercise and mortality. So those people burning 200 calories per week in exercise versus 200 calories per day, those patients burning very few calories, markedly higher mortality rate. Balance is particularly important. There's Tai Chi and other balance programs. I always get frustrated when we screen for falls. We should be sending everybody for fall prevention. Falling is an inevitable consequence of aging. You should teach people to prevent falls and send them before their first fall. We know that when people do fall, it's extremely common. A third of people over the age of 65 will fall per year. Of that, about 10% will have significant morbidity. If they're Caucasian or Asian, they tend to fracture hips. If they're African American, they tend to have intracranial bleeds. Neither of those are particularly good. So I would encourage people not to wait for the person to fall, but to send them for fall prevention, particularly if they're frail. So what do we do about prevention and falls? There's lots of things you can do. And so a little bit of a tight box down here off to the right. But you can minimize medications, you can tailor exercise programs, you need to treat vision and make sure they're wearing proper shoe care, make sure that they're not having vascular instability issues, supplement with vitamin D. There's many things that you can do to improve a patient's risk of falling, and these should be done on a routine basis. And you don't have to wait till they're on hospice. This should be done, years, even decades before hospice. It's always better to prevent a problem than to wait till that problem started and try to treat it afterwards. There's other issues associated with sarcopenia, the loss of muscle loss. We know genetics is a part of it. Increased cytokine levels, that's the inflammatory process. The more inflammatory procedures we're exposed to, hospitalizations, infections, surgeries, medications, that increases the cytokine production. Decreased hormone production. As we get older, we know our hormone production decreases. Oxygen-free radicals. That has to do with eating and normal nutrition. Mitochondrial metabolism produces oxidants. The more you eat, the more oxidants you produce. There was all these models coming out about intermittent fasting, and I think that definitely relates to the issues about producing free oxygen radicals. You can't get rid of free oxygen radicals, and you probably shouldn't get rid of them completely. But one of the problems we have is the overconsumption of calories overproducing oxygen-free radicals. There's motor nerve end plate problems, anorexia and malnutrition, which we can deal with. Decreased cognitive function lowers our ability to exercise, so patients become less likely to exercise their muscles and they'll lose muscle mass, and of course mobility decreases. It becomes very complex, but it is a part of all of this physiology and hormonal and cytokine strategy that's keeping people from deteriorating in frailty. Some of the best mechanisms to improve the fatigue component, and this is particularly in late stage, but many of these things, and you get the idea, move many of these things upstream to preserve people's energy so they can use it on more important issues, such as the exercise we just talked about, but change the environment. Give a patient a bedside commode, move the phone closer to their bed, let them work on walking around the house or around the apartment more than trying to get to the bathroom. Room temperature matters. Reorder tasks, get up and eat, rest, then bathe, not the other way around. Modify procedures so they're not standing during showering and then they're not showering except twice a week, but maybe if you have them sit, it would be better. Increase their activity. Exercise increases activity, and it doesn't matter what age. It's hard to convince some people about that, but once they start to exercise, they actually feel better. I cannot overemphasize eliminating medications, particularly medicines that slow patients down. Beta blockers, antihistamines, tricyclics, anticholinergics, all of these medicines, we see our patients on these medicines all the time, especially in our community-based palliative medicine program. We are stopping them routinely years prior to their demise, and they actually do better. And if you really want to be more aggressive, you can think of psychostimulants and consider using those to increase the energy in your patients. So de-medicating the elderly is particularly important. People should learn when to stop medications, and they should stop as many medications as possible. There is a stop and a start program, STOPP and STRAT programs, and there's other programs, Beer's criteria, that help you to understand when medicines should be stopped in the elderly. And we cannot continue medicines indefinitely because the underlying physiology is changing. So every year or two, you need to reevaluate your patient's medication list and ask, is this still an appropriate medication for this patient at this time in their life? Weight loss, one of the things that you can do is to recognize, you have to recognize the problem earlier. The problem is weight loss is an inevitable consequence of getting older, as your body's ability to metabolize nutrition and your hunger and caloric intake drops. Supplementation has been evaluated repeatedly and may not be as effective as we would have hoped in the past. I'm just going to show you a few research articles. I worked many years as a expert witness defending physicians because their patients were dying, and the family actually sued the physician, but the physicians had not been aware of all of the warning signs to tell their patients about or their families about because they just didn't know. And one of the things is patients start to lose weight, and there's not a whole lot you can do about it when it's far enough along in the process. So if you're going to intervene, you have to do it earlier on. But this was a research article just to show you there was 34 trials, about 2,500 participants, and they looked at supplements containing protein and calories, and they had little or no effect on weight gain, and there was no effect on strength or function. It's too late if you waited too long. This was a Cochrane review, 62 trials, over 10,000 patients. They looked at the mean difference in weight, which was about 2.2% in 42 trials, but there was no significant reduction in mortality in the supplemented versus control groups for malnourished patients. Once again, what does that 2.2% represent? It represents stuffing the intestines full of isocal, longevity, and nutrition, but it wasn't going anywhere. And in fact, when, as I discussed in our previous presentation, when we stuck feeding tubes in these patients, it just causes aspiration pneumonia and increased risk of pressure ulcers, and these patients actually did worse. And what we should notice is that mortality results with supplementations were statistically significant for patients defined as undernourished. Once again, if you catch the patient earlier in the process, there may be some benefit. One other slide I want to show you. This is an older slide, but it's been very powerful in me learning about frailty and understanding the process. And this was a study where they took 500 feeding tube patients in a well-controlled nursing home. And they followed these patients over years. And it was about a 5-year study. A third of these patients started to lose weight, despite the fact they were being treated exactly the same than they had feeding tubes in them. And what they showed, or the conclusion was that these patients had adequate calories and protein being provided with mean samples exceeding standard means for energy, protein, and micronutrients. Still, these subjects showed weight loss and severe depletion of lean and fat body mass. The study showed that despite the administration of apparently adequate formula, micronutrient deficiencies, and marasmic malnutrition existed in these chronically ill patients. Eventually, they just lost the ability to metabolize the nutrition. And they looked at these patients and they went back and did necropsies to see if they developed cancer or some other problem. And the answer was they hadn't. It was the underlying physiology that had changed, and these patients were no longer able to utilize the nutrition that was being provided to them. I would point out that these patients, when they started to develop marasmic malnutrition, 2/3 of them developed pressure ulcers. So there's a physiologic process, and these are warning signs. So when a patient develops pressure ulcers and they're losing weight, people should be thinking differently about their patients. So the conclusion to all of this, if there's limited effect of supplemental nutrition on outcomes, is because the underlying cause of weight loss in frail patients is due to the low-grade inflammation and neuroendocrine dysregulation, preventing that nutrition from being metabolized. These patients are not starving, and they are receiving adequate nutritional intake. It's just that they can't utilize that nutrition any longer. And the proactive discussion of this particular phenomenon for your advanced elderly patients in my practice has been particularly powerful in letting them know what's coming so that they can deal with these changes. So I always tell patients that end of life can be ugly, because if you live long enough, you're just going to wear out. And the things that we see, particularly when patients have primary or secondary frailty, are these wasting syndromes. Cachexia, sarcopenia, they'll become confused, they'll have more infections, they will get bed sores, we now call those pressure ulcers. But this is a part of the life cycle, and it should be anticipated that we can see this coming. I actually gave this a name because I believe it's actually a third endocrine problem. I call it mortipause. You can't look this up on the internet. This is my word, but to me, it reflects that change in ratio over time when patients don't have stem cell mediated recovery. Their pro-inflammatory cytokines are going up, their anti-inflammatory cytokines are going down, and that's when the patient's physiology starts to change and they're entering the end of life. And we've done this by introducing those pro-inflammatory cytokines into animal models, and we can accelerate their aging and watch them die more quickly. And the reverse of that is to decrease your oxidative metabolism by intermittent fasting or simply reducing calories and exercising and changing that ratio of pro and anti-inflammatory cytokines. So what do you want to do if you're dealing with patients that are eating less and having less nutritional intake, especially if you caught them early? Give people their food of choice, ethnic foods, foods that they prefer. I used to work in nursing homes for 25 years. Patients would come in with 1,800 calorie, low fat, low salt, cardiac, ADA diets, and we'd scratch it out and say, eat whatever you want. We'll deal with the sugars and the heart disease. Because if you didn't do that, the patient wouldn't eat and they would die. They would die quicker. So we learned over time, in some patients, you get rid of the tighter traditional management and you let them eat what they want. Some articles would say provide alcohol, especially if they're a person who's used to having a glass of wine with their meals. Smaller, more frequent meals. Good oral care is particularly important. Now, you can try to give nutritious foods, but if they're not going to eat nutritious foods, it's better to eat anything. Now, supplements may help. You need to treat depression and pain. Absolutely eliminate medicines. Once again, eliminate medicines that make it difficult to swallow, particularly anticholinergic medicines, medicines that cause dysgeusia or bad taste in the mouth. And socialization with meals has been shown to be beneficial. We are social creatures. We like to be around other people. We may eat more if we're surrounded by other people. One of the things I can tell you is the FDA has not approved any medicines for weight loss. Magestrol has some scientific evidence after surgery or cancer patients, but otherwise, just to put a patient on Magestrol for weight gain at 26 weeks, there was no evidence of improvement in outcome. They did gain weight, but there was no evidence of improvement in outcomes. There is risk of blood clots, hypocortisolism, and diarrhea with that medication. If you're going to use an antidepressant, the American Geriatric Society does not recommend mirtazapine unless the patient is depressed, although SSRIs may have some benefit on patients by improving their mood, and hopefully they'll eat a little bit more. It's probably worth a trial, but I wouldn't expect the outcomes to be particularly glowing. One last comment, because what about the rest of us? What about patients who aren't frail and prolonging life? And this has been very popular in the literature these days. Calorie restriction has been proven to be the most effective method of extending median and maximal life expectancy in multiple mammalian species. This was an article published about 2 decades ago. And I remember at UCLA in the 80s when researchers were actually fasting one day, and then they'll have water and vitamins, and the next day they would eat normally, because in every mammalian species they studied, where they fed them one day and not the next, those patients, those animals, those mammals were living 50% longer. Now, what does this do to your body? It decreases your fat stores, and that decreases your pro-inflammatory cytokines. Calorie restrictions also decreases the rate for which proteins are oxidized, because when you eat, because of that normal mitochondrial metabolism, you produce superoxides, hydrogen peroxide, hydroxychloric acid, and nitrous oxide. And since those oxides damage your cells, you expend your stem cells by stem cell mediated repair. You don't want to do any more of that than you have to. And so if you want to live longer, you have to slow the process down. So calorie restrictions believed to be the best counteraction to stress-associated oxidative damage. Now, you have control of about 25% of your oxidative process in your body. The other 75% is just a consequence of being born. You can't fix that part, but the 25% you can. There's a significant amount you can do, and calorie control can help you out. Also helping you out could be eating an anti-inflammatory diet, Mediterranean diet, any diet that lowers oxidative production and has some antioxidants in the meal itself. So in conclusion of all of this regarding weight, this is always a big issue when I would do expert witness. Weight loss in the non-morbidly obese geriatric populations associated with increased mortality, even voluntary weight loss in some studies. So people need to be aware that has to do with the loss of muscle, because you lose 25% of muscle when you're older, and this is for the advanced elderly. Dieting without exercise accelerates sarcopenia, so you do want to make sure your patients are exercising no matter how old they are and no matter what they can do. I always tell my patients, don't tell me what you can't do, tell me what you can do. And if it's just walking around your apartment, do it. If it's lifting a soup can 10 times, 5, 10 times a day, do it. Whatever you can do, it will help you out. If you hold on to the counter and do a couple squats, that's better than 0 squats. So the other issue is increased fats associated with increased pro-inflammatory cytokines and increased muscles associated with anti-inflammatory cytokines. So you see the value of keeping that ratio under better control. And weight loss, which spares muscle, and dieting is the exception, especially if you can have that patient exercise. There's other issues you'll see with frail patients in particular, as all of this process starts to progress and their adipose tissue is going up and their fat tissue is going down. You'll see vitamin deficiencies. 3 vitamin deficiencies has been associated with frailty. Here's a little mnemonic you can remember: food intake, resistance training, atherosclerotic prevention, isolation avoidance, particularly important, limit pain, Tai Chi, or yearly testosterone check, although we don't know about that yet. Here's another mnemonic which I created, which is De-Frailty. You want to keep people from being frail. Treat depression, check endocrine issues, and we'll find out more about endocrine issues in the future. Monitor food intake to proper dieting, resistance training in addition to cardiovascular training. Atherosclerotic heart disease prevention is particularly important. Prevent isolation, very bad for patients. Limit pain, Tai Chi for balance, and medication review annually. So what about the prognosis as we finish up here for frailty? We know that for primary frailty, mortality is about 300 to 500% higher in frail than pre-frail or no frail patients. The process of frailty starts with acute phase response. For us, we go to recovery. Normal cytokine levels return, we improve, and we're discharged from the hospital after a trigger event. A frail patient develops a pneumonia, goes for a surgery. You have acute on chronic phase inflammation. You have elevated cytokines. You get a negative energy metabolism, which leads to hypercholesterolemia, anemia, hypoalbuminemia. It can either cycle around and then eventually the patient dies, or the patient can die immediately. This is why the mortality rate for advanced dementia patients who fracture a hip is about 53 to 55%. It's exactly the same number for an advanced dementia patient that develops a pneumonia. You can look at those biomarkers of the frailty process, and this is from the cardiovascular health study. Doesn't matter whether hemoglobin was lower or higher, their mortality rates are higher, so you can look at those numbers. independent of cause. You can look at inflammatory markers, particular markers for frail patients, IL-6. We use surrogate markers, CRP, highly sensitive CRP, SED rates. Those things do help us as well. You can look at prognosis with visceral protein. We know that elevated IL-6 and elevated CRP is associated with lower albumins, and albumins are associated with increased morbidity, mortality, and disability. Age-related changes appear to be due to changes in synthesis and degradation. You are losing protein synthesis as you get older. So if you put an inflammatory process on top of a patient who already has a low albumin, you can expect them to have higher morbidity and mortality. There's a particular study that showed that. It wasn't even for frail patients, it was for all patients, but it includes frail patients. 15,000 patients, age 40, albumins less than 3.4, which was about 1/5 of the population. The hospital mortality was 350% higher for those patients than patients with normal albumin. And hypoalbuminemia in frail patients is extremely common. These patients had longer lengths of stay, more likely to be readmitted, and if readmitted, done so sooner. This just shows you that over time, you can use prognostic markers that work not only in frailty, whether it's mortality. You can see age going up here. You can see albumin dropping here. The older you get, the more prognostic that albumin is of a bad outcome, whether it's mortality, length of stay. You can put readmission on here as well. One of the articles I used to use in the nursing home was to monitor my patient's albumin. When it dropped below 3.5, I would have a palliative hospice discussion about goals of care with the patient and family. Even if they lived longer, they were emotionally prepared for the inevitable outcomes. Half of these patients were shown to be dead within 1 year. Just to show you can use cholesterol, which is a part of that acute on chronic inflammatory process we see in palliative patients. This was for nursing home women, J-shaped relationship between mortality and serum cholesterol. The article controlled for age, blood pressure, weight, heart attack, kidney problems, plasma proteins, cancer. Only one patient was found to have cancer on necropsy. Excluded smokers, persons on cholesterol medications, liver disease, acute illness. They had to be in the nursing home for 6 months or more. And the mortality rate was 520% greater in cholesterols of 4.0, that's 155 milligrams per deciliter, than in patients at the nadir of mortality of 7.0, which is 270 milligrams per deciliter. Now, I'm not going to go into the dozens, if not a couple hundred research articles that show in the advanced elderly, if you see a dropping cholesterol or a total cholesterol that is extremely low, that is highly associated with mortality. And that compares to 180% higher increase in mortality if the cholesterol was 8.8. That's 339. So high cholesterol, yes, there is higher mortality, but it's these really low cholesterol, 520% increase that prognosticates particularly for the advanced elderly. Same story for men. Low cholesterol is less than 150. The rate was 63% at 14 months versus 9% if their cholesterols were greater than 150. If you ever ask, where do you want your patient's total cholesterol? I try to keep it above 150. One last study, 10-fold increase in dying if the patient had low cholesterols, 2-fold increase with high cholesterol. Nadir was 4.7, so 181 milligrams. If you added that to low albumin, low hemoglobin, and BMI, all of these things increase mortality by 400%. And all of this was associated with outcomes that we connect to poor long-term survival. One last study. As a matter of fact, I believe this might be the wrong citation. My apologies. I can get the correct citation if you request it. For patients in the study, they had low cholesterol, low hemoglobin, low albumin. Mortality was 84% at 1 year versus 7% if they did not have a low albumin, low cholesterol, and low hemoglobin. That is one of the most powerful prognostic markers you can have, the triad of those 3 low markers. Just going to show you can use this when you send your patient to the hospital. You have a frail patient, their cholesterol start off low and stay low. Mortality is about 32% if they go to the hospital, including heart disease patients. And if they start normal but go low, also greater, higher morbidity, greater lengths of stay. They're more likely to have had surgery, not eating for 5 days, more complications, and slightly more higher mortality rate, although it's a small sample size. So I want to show you 1 or 2 other articles to show you the value of using these tools to prognosticate. This was elderly patients who developed pneumonias. They looked at this in nursing home residents. They followed multiple markers to prognosticate outcomes. And they looked at diagnosis, demographics, ADL status, cognition, vital signs. They looked at laboratories, comorbidities. And what did they find? The risk factors most likely to prognosticate not surviving a pneumonia in a nursing home patient were complete ADL deficiency followed by renal function, albumin, and cholesterol. Now, it seems very odd, but nursing home nurses would call me and say, your patient seems to be having some respiratory distress. And my first questions would be, what's their renal status, what's their albumin, and what's their cholesterol? Because I want to know where this patient's going. And the other interesting thing about this is if you're monitoring these laboratories, you know this before the patient develops their pneumonia, and you can use that to help prognosticate risk and have discussions with families. And this all relates back to that pro-inflammatory cytokine suppression of the production of things such as cholesterol and albumin. I'm going to walk you through an example of a case that helps you put this all together. This was a patient I inherited out of the hospital. The patient had moderate heart failure and dementia, had a tib fracture, was in the hospital overnight. Because of his dementia, he was sent to a skilled nursing facility. One of the basic prognostic models you need to know is that about 20% of Medicare discharges go to skilled facilities. Of those Medicare discharges to skilled facilities, about 2/3 go home and 1/3 become custodial. Greater than 50% of the custodial patients will be dead within a year, and the others live for a few years. So you can already imagine this patient is on a pathway that's not particularly good because he has heart failure and dementia, and it's hard to get those patients back into assisted living or home care. So not surprisingly, predictably, he became a long-term custodial patient. But as I monitor him over time, you can look at all the prognostic tools, and many of these relate to the frailty process. We didn't talk about psychosocial prognosis, but this patient was the facility greeter for some time. I would go in and see him. He eventually became socially isolated. You can watch the fact that he was losing weight eventually. That just happened, as we talked about. You can look at his ADL decline. He started out with just a few deficiencies, but that progressed over time, as would be expected with a frail patient. You could look at his biomarkers, and his albumin dropped, and his cholesterol dropped, and his creatinine dropped because he was losing muscle mass. So I could prognosticate in 2012 that this was a hospice appropriate patient. And just to help with the patient's management, I talked to the patient's family. I talked to the staff because they need to be emotionally resolved as well. I warned them he's going to get infections, delirium, and pressure ulcers, which he got all 3. And then he passed away, but he had already been placed on hospice because this is the inevitable consequence of a predictable pathway. And that's how you use your professional schools to prognosticate for patients with frailty. So in conclusion of this presentation, we need to recognize that frailty is highly under-recognized. It's an independent diagnosis. It's progressive but treatable. but that predictable course has significant prognostic consequences that need to be shared with the patient and the caregivers surrounding the care of that patient. So I just want to say once again, thank you very much. I hope that was helpful to you. I hope you go and learn a little bit more about frailty and the importance of choosing the proper frail model, and you integrate that into your daily practice. Thank you very much.